Now, coming to my presentation, I'm actually going to talk about our experience with community health workers. And as I do that, I will be talking a little bit about a history and the context of how we came about it. And then we'll talk about how and what have we achieved all this time, and especially with regards to incentivizing them. So in terms of historical context, BRAC was actually started working after the liberation of Bangladesh, when a lot of refugees were coming back from India. And what happened was, as BRAC was started to work with the rehabilitation support, very quickly the founder realized that it's sort of a band-aid solution. It's not really necessarily doing any long-term development. So it was a good realization immediately that it's not the rehabilitation, it's, we need to work on development. That has been pretty much the motto of, or the philosophy of how we want to work. As you can see, BRAC is a development organization, and we dedicate our effort on alleviating poverty. And the way we do it is that it's the poor, organizing them and empowering them so that they can come out of poverty on their own, rather than us going, and we as a BRAC, we go as a catalyst rather. So our mission and goal is to empower people and communities in situation of poverty, literacy, disease, and social injustice. So as you can see, healthcare intervention have been a very integral part of our work on alleviating poverty. So as we see, at the very beginning, as the health program was integrated, because poverty, we know, is multidimensional, and we needed a very comprehensive approach, and that's where health came in. And we started in 1973. So if we look at our comprehensive approach, as I was saying, that as we organize the village as a village organize the village in the microfinance group, what we realize is that as we help them with the financial support, we also need to help them with health and also poultry, like agriculture, livestock. So improving their livelihood is a very big part of what we do together with health, because we know that there could be catastrophic expenses of healthcare if they are not well, and it's the entire idea of alleviating poverty is not going to work. So we work within that comprehensive approach. In terms of Bangladesh Health Nutrition Population Program, I guess I already talked about the approach. So the model has the community health promoters. It's providing preventive, promotive, curative, and rehabilitative care, and it's driven by our overall holistic approach to development. And our aim is to improve reproductive, maternal, neonatal, and child health, nutrition status, and reduce vulnerability to communicable diseases, combat also non-communicable disease, and enhance the quality of life overall. And in terms of scale in Bangladesh, currently they've been working in 64 districts and reaching about 120 million population. Oh, okay. So the model has community health promoters. In Bangladesh, they call them Shastoshebikas. And they are basically community members, and the selection criteria are there. So it's between 25 and 40, and at least are literate, has fluency in reading and writing. Willingness to work is, of course, very, very important, and social acceptability, and work as a volunteer. And in Bangladesh, the household that they used to look after is around 400 to 500, given the density of population. So there, as you can see on the left, there's a Shastoshevika, and what we also have on top of it is a layered Shastokormi, who is a health worker who's actually a cadre under, it's a salaried cadre, who will do the supervision of the community health workers, as well as provide certain additional services, especially around ANC and PNC. And they also actually have a nominal honorarium. Now, incentives in Bangladesh, coming to that is there's two types of incentives. One was the social, because these ladies are in the community, and once you empower them, train them to be a community health worker, they do gain a lot of respect from the community, and they're called the community doctors, which has always worked as a positive social incentive. But on top of it, the financial incentives, we have a layer of it. One was the revolving fund. It's a loan-free, sort of a interest-free loan that we provided for each CHP. There is a certain amount of money that she can use to purchase health products. And coming to that is that the sales of those products into the community becomes like the margin they receive from it becomes sort of their supplementary income. Because they're volunteers, this is sort of a built-in entrepreneurial mechanism we have in place. It achieves two things. One is that we have a supplementary income source for the community health workers, and secondly, we don't run out of input supply. So we have a continuous flow of medicine and health products, basic ones at least, over-the-counter ones, and health commodities like hygiene products, that is also available into the community, and also programmatically because it's a revolving fund. So CHPs purchase it, and then she sells it, and then she comes and repurchases it, and then the money we continue to use for sort of purchasing it for the CHPs through the programs. And also, with those two, we also have a performance-based incentives. That one has pregnancy identification. It's a component-specific. Referrals for complications. We have IYCF and MNP compliance, one under the nutrition program. And of course, TB treatment compliances on DOTS. So those are the performance-based incentives we have tried with the community health workers in Bangladesh. And also, on the fourth one is the selling services. So we train CHPs on non-communicable disease screening, especially for diabetes and hypertension screening. So once they do that, the person they're screening is the one she can provide a service charge, a nominal one. And of course, then they're tied to the referrals to the health centers for more tests and all. So after trying and testing, and I just wanted to give you a few numbers on the results that have, BRAC has contributed in terms of maternal and child health in Bangladesh. We have, in BRAC areas, we have 91% immunization coverage as opposed to the national 85% coverage. So, and then in terms of MDG Goal 4, its neonatal mortality rate in BRAC areas was only 18 out of 1,000 live births. And MDG Goal 5, the maternal health improvement, we see that the BRAC areas, the maternal mortality ratio is 115 out of 100,000 live birth, whereas the national MMR is actually 194 out of 100,000. So it's proven that through this model, they can significantly attribute to maternal and child health and overall health. In terms of even TB DOS, we see the treatment success rate in BRAC areas is 95% as opposed to national average of 85%. So once as we were becoming more successful, we also tried to realize that, can we translate these decades of community health work experience and have similar impacts in other countries, especially in the context of African countries? And the answer is actually very much yes. And as you can see, in Uganda, we have currently 4,075 trained community health promoters. South Sudan, we have 120 CHP and 200 community-based distributors. Liberia, we have around 600 CHP, and Sierra Leone, 406 CHPs. The essence of the BRAC CHP model was intact, and all the best practices that we have found to be fruitful in Bangladesh have been already incorporated into the models on each of these countries. And those primarily are, of course, the CHPs are providing basic health care and within the community, and then sales of the health products, built-in entrepreneurial model and for sustainability, and strong government linkages, refreshers on a monthly basis, and supportive supervision, monitoring and evaluation, and of course reports. We have the key performance indicator laid out, and it's very easily measurable, and we have a target versus achievement performance review. Now, I'm going to talk a little bit more about the Ugandan context, given also we have a large operation there, and as well as some impact achievements that I can share with you. So we started in Uganda in 2008, and it was the essential healthcare, the Shastoshebika models, taken into the context of within Uganda. So it's to have a heavy focus on maternal and child health, and the current coverage is 3.6 million, and we have, as I said, 4,075 community health promoters. In terms of impact achievements, we've done RCTs, and it was conducted by the Stockholm University together with IPA JPAL, and it shows 21% mortality reduction among children under 5 within the BRAC CHP treatment areas versus the control with no CHPs. We also had RCTs done, and where it shows a spillover effect on the market price of the malaria treatment. And also we see that where CHPs are selling the SET, not only the price have lowered, the counterfeit drug has been lowered in those areas. So it improved access, quality access of SETs, as well as the price of SET. The other studies also have shown that BRAC CHP's areas, we have been able to improve demand and also service uptake, especially around PNC, ANC, and also family planning. So moving forward, in terms of scale out, we have expanded last year quite significantly with 45% growth. And in terms of scale up, and I think that's pretty relevant here because we are talking about adding components to the CHP's work, is that we have been also enhancing their skills in terms of full ICCM, so they can treat diarrhea, pneumonia, and malaria. They can do MRDTs for malaria, family planning, nutrition, and also we're incorporating mobile technology, which I'm quite excited to actually share with you. So in terms of innovations, built-in entrepreneurial model, as I said, that is a big edge that we have in terms of sustaining CHPs and have them to have a supplementary income. Technology incorporation, every CHPs are currently, as we speak, are being trained to use mobile applications to register households, identify, provide like pregnancy, and then also seek child assessment. So it does two things. It has, of course, reporting real time, but most importantly, it also has screening tools built in. So so any CHP at any given point, it will be using the same screening tool with a similar diagnostic. So it also has a way of sort of improving the quality of the care across. And incentive scheme testing. So currently we are also testing additional incentives here within Uganda. Supportive supervision. Our CHPs are rigorously supervised and trained and certified. So that is a very important aspect of our innovation, we believe. And we have certification and recertification and quarterly knowledge test, and every CHP needs to kind of maintain their standard. It's not just one time you train and that's pretty much it. And also, we are providing them enhanced nutrition and family planning training. And with regards to family planning, I just wanted to add that we are also going to be testing Cyanopress through CHPs. The government of Uganda has allowed VHD or community health workers to be able to provide this Cyanopress to their community. So CHP's platform will be one of them to see whether it is successful in terms of training, skill development, and seeing whether it has improved the uptake of the Cyanopress. So incentives experience, monetary experience, incentive experience is the sales of the products, so and the supplementary income, and then performance-based incentive, which is the component specific. These are experiences in Uganda, and social incentive wise, as I said, community recognition and respect. When CHP will say that I actually didn't even know barely, how to take care of myself, but now with the training and all the work that I've been doing, I can take care of myself. I can take care of my family and the community. Not to mention, I can stand up in front of a crowd and talk about a health component. Okay, so together with the social incentive, we have CHP awards and recognition. So every once a year, we have a CHP Appreciation Day, and we have a rigorous system where we choose and select CHPs whom we award as the best CHPs of the year. And then we have certification, as I mentioned earlier, and technological inclusion. Challenges and successes. Well, like any other intervention, it has its pros and cons. So in terms of monetary incentive, what we see is that the focus sometimes shifts to the component where we have put the incentive, and I think it's only natural. And sometimes we do see, operationally speaking, some over-reporting issues, and monitoring sometimes becomes quite cumbersome, because if we have a monitoring monetary incentive, we do want to rigorously check and see whether it's fine and whether the CHPs are meeting the criteria. So doing that sometimes cost, we realize, is more than the incentive itself. And sometimes we see that CHPs who heavily rely on those incentives, they tend to get demotivated. And also donor-focused differences. Sometimes, every donor has their different focus, and they want to only incentivize those particular things. And as BRAC, we know, and as a public health worker, that everything is connected. So we do want to have a holistic sort of approach to even monetary incentive. So, and in terms of policy environment in Uganda, there is a lot of mobilization of fund and advocacy on new CHU strategy. So that's in there, and CHU will be a paid community health worker. And also there's talks about VHT's discontinuation of the whole VHT model and the system. So that's sort of another environment where we are looking into how the CHP will Okay. Challenge on social incentives is that even though if it's a social recognition, sometimes it still does require funding. For example, CHP Appreciation Day or even certification. Built-in entrepreneurial system is successful. I mean, it has been successful in Bangladesh, and even in Africa, we have been able to be successful. But once again, it does require a certain level of business skills development of the CHPs, which needs to be put in place. Success, improve performances on specific components with monetary incentives, especially regarding treatments and pregnancy. And even though the short term, the CHWs, like if we have a monetary, let's say, incentive for a particular treatment or pregnancy, even if it is short time and donor sort of funding based on availability, what we see is that the CHP still sort of appreciate that, and then it becomes a matter of expectation management. Revolving fund, as I said, we have 100% recovery of the input supply. So we have CHPs who are purchasing from us, and then we purchase it for them. So it continues, and we don't run out. And my final slide on lessons learned. Accountability and transparency with strong check and balance is required, regardless whether it's a social or monetary incentive. Advocacy is required as we multiverse our CHPs onto different components. Sometimes we see that government has policies which does not allow CHPs to do certain things. So advocacy is a very important aspect of it to ensure that the CHP scope of activities are broadened. Innovation and flexibilities, learning by doing. I'm sure, many of us have already presented that lessons learning, and it's the similar here. Expectation management at all levels, CHW, community, staff, and government. It's extremely important that that communication is there, that this is based on this funding and up till this. Most importantly, more robust and and primary healthcare coverage that we make for CHPs actually does sometimes do make it sustainable and carry on the platform. And entrepreneurial model do require, as I say, the investment for outreach and business skills together with the health skills. And I promise this is, I'll spend 20 seconds. So we're trying some new incentive schemes where we are scoring CHP's overall performance so that she doesn't weigh on one thing or the other. And we're going to check which one really enhance CHP's performances and then take from there. Input supply loan, we are trying, we have 45 CHP per person of our CHPs who are already microfinance borrowers, but then we have 55% who are not and who does have issues with input supply money. So what we are planning to do is have a system or mechanism in place for them to have microfinance for the input supply for health program, health products. And then sales of services. We are going to test this year the Siena Press and Depo-Provera training, as I was mentioning earlier, and see whether a service charge can be added and see how it goes from there. So thank you very much for listening.